Your liver has no pain receptors. That single fact is why liver disease kills silently, and why most people who have it don't find out until it is already serious. Here are the 8 signs your liver has been sending, what they mean, why they happen, and the ones that mean the liver has already moved past the point of quiet warning. Sign 1. Fatigue that sleep cannot fix. Not tiredness. Not the kind that improves after a good night. A fatigue that sits in the body like weight, present in the morning, present at night, unresponsive to rest. The liver performs over 500 metabolic functions daily. It processes every nutrient absorbed from food, detoxifies the blood, produces bile for fat digestion, synthesizes proteins, and regulates blood sugar. When liver cells are damaged or inflamed, each of these processes slows. The body is running on a compromised engine, and fatigue is the most immediate result. Liver-related fatigue is also driven by the accumulation of toxins the liver can no longer efficiently clear. Ammonia, a byproduct of protein metabolism, normally converted to urea by the liver, begins to build in the bloodstream. Even at subclinical levels, ammonia impairs brain function, disrupts the sleep-wake cycle, and produces a persistent heavy exhaustion that no amount of sleep resolves. A 2016 study in the Journal of Hepatology found that fatigue was the most commonly reported symptom in patients with non-alcoholic fatty liver disease, present in over 65% of cases. And critically, it appeared years before any abnormality showed on liver function blood tests. The fatigue arrives before the diagnosis. Most people never connect the two. Sign 2. Yellowing of the skin or eyes, jaundice. A yellow tint to the whites of the eyes. A slightly golden tone to the skin. Easy to miss in artificial light. Impossible to explain away once you know what it means. Jaundice occurs when bilirubin, a yellow pigment produced from the breakdown of red blood cells, accumulates in the blood. Under normal conditions, the liver captures bilirubin, processes it, and excretes it into bile. When the liver is damaged, inflamed, or obstructed, this processing fails. Bilirubin spills into the bloodstream and deposits into skin and the whites of the eyes. The eyes show jaundice first, before the skin, because the sclera has a high affinity for bilirubin. If the whites of someone's eyes have taken on any yellow tone, the bilirubin level in their blood is already significantly elevated. This is not a cosmetic observation. It is a direct readout of liver function failure. Jaundice in adults is never normal and always requires investigation. The causes range from acute hepatitis to bile duct obstruction to liver cirrhosis to pancreatic cancer compressing the bile duct. The specific pattern, whether bilirubin is rising from liver cell damage or from a blocked bile duct, changes the diagnosis entirely, which is why jaundice in any degree warrants same-week medical evaluation, not watchful waiting. Sign 3. Abdominal swelling. A bloating that does not come and go with meals. A belly that looks and feels distended, particularly in the lower abdomen, and does not flatten overnight. This is not digestive discomfort. In liver disease, it is fluid. Ascites, the accumulation of fluid in the abdominal cavity, is a direct consequence of advanced liver disease. It develops through 2 mechanisms simultaneously. First, a damaged liver produces less albumin, the protein that maintains osmotic pressure and keeps fluid inside blood vessels. Without adequate albumin, fluid leaks out of vessels and pools in the abdomen. Second, portal hypertension, elevated pressure in the portal vein that feeds the liver, forces fluid out of the intestinal blood vessels into the abdominal cavity. The result can be dramatic. Ascites can accumulate 10 to 15 liters of fluid in the abdomen, the equivalent of carrying several gallons of water inside the belly. The abdomen becomes visibly distended, taut, and uncomfortable. Breathing becomes shallow as the fluid presses upward on the diaphragm. Ascites is a marker of decompensated cirrhosis, the stage where the liver can no longer maintain basic functions. Once ascites develops, the 2-year mortality rate without treatment or transplantation is approximately 50%. Its appearance is not a warning that the liver is struggling. It is confirmation that the liver has already been losing for years. Sign 4. Dark urine and pale stools. Urine the color of strong tea. Stools that are gray, clay-colored, or pale. These 2 changes, appearing together, are among the most specific signs the liver and bile system are in trouble. Bile, produced by the liver and stored in the gallbladder, is what gives stool its normal brown color. When bile flow is obstructed or liver function is severely impaired, bile does not reach the intestine. Stool becomes pale, greasy, and difficult to flush. At the same time, bilirubin that cannot be excreted through bile is instead filtered by the kidneys, turning the urine a deep amber or brown. These two changes happening simultaneously, dark urine and pale stool, indicate obstructive jaundice, a condition where bile is physically blocked from flowing. The most common causes are gallstones lodged in the bile duct, inflammation of the bile ducts, or a mass, including pancreatic cancer, pressing on the common bile duct from outside. This combination requires urgent evaluation, not a scheduled appointment in 2 weeks. Obstructive jaundice left untreated leads to liver damage, ascending infection of the bile ducts called cholangitis, which can be life-threatening within hours, and progressive organ failure. The urine and stool are telling a precise story. The question is whether anyone is listening. Sign 5. Itchy skin with no rash. An itch with nothing to see. No hives, no redness, no dry patch to blame. Just a persistent, maddening itch, often worse at night, that no cream touches. When bile flow is impaired, bile salts, the detergent-like compounds in bile, accumulate in the bloodstream and deposit in the skin. These salts are intensely irritating to nerve fibers in the skin, producing a deep internal itch called pruritus that is fundamentally different from surface-level skin dryness. It cannot be scratched away because the cause is inside the blood, not on the surface. Cholestatic pruritus, itch caused by bile salt accumulation, is one of the most debilitating and least recognized symptoms of liver and bile duct disease. It affects up to 80% of patients with primary biliary cholangitis and is common in intrahepatic cholestasis of pregnancy, bile duct obstruction, and advanced hepatitis. The itch tends to be worst on the palms and soles, a distribution pattern that is clinically distinctive and rarely seen in ordinary skin conditions. A patient with generalized itching, no visible rash, no response to antihistamines, and worse symptoms on the hands and feet has a hepatic or biliary cause until proven otherwise. This symptom is frequently mismanaged for months as a dermatological problem before the liver is investigated. Sign 6. Spider veins and skin changes. Small, red, spider-like blood vessels appearing on the chest, shoulders, or face. A redness spreading across the palms. These are not cosmetic. They are vascular signs of a liver that has lost control of circulation. Spider angiomas, dilated capillaries radiating outward from a central point like a spider's legs, appear when the liver fails to metabolize estrogen properly. Elevated estrogen causes abnormal dilation of small blood vessels near the skin surface. More than 5 spider angiomas on the upper body is considered clinically significant for chronic liver disease. They appear most commonly on the face, neck, chest, and arms, above the waistline, because the distribution mirrors the drainage territory of the superior vena cava. Palmar erythema, a redness of the palms, particularly at the thenar and hypothenar eminences at the base of the thumb and little finger, results from the same mechanism. Elevated estrogen and impaired vascular regulation cause increased blood flow to the palmar surface. Up to 23% of patients with cirrhosis have palmar erythema as a finding. Other skin signs include caput medusae, dilated veins radiating outward from the navel, visible through the skin, caused by portal hypertension forcing blood to find alternative routes around the blocked liver. When these veins are visible on the abdomen, the portal hypertension is already severe and liver function is significantly compromised. Sign 7. Confusion, memory loss, and personality changes. A sharpness that has gone dull, forgetting words mid-sentence, a personality that has shifted, more irritable, more withdrawn, harder to reach. When it happens gradually, everyone assumes it is stress or aging. Sometimes it is the liver. Hepatic encephalopathy occurs when the liver can no longer adequately clear neurotoxins, primarily ammonia, from the blood. Ammonia crosses the blood-brain barrier and disrupts neurotransmitter function, alters brain cell volume through osmotic effects, and impairs the neural pathways governing attention, memory, and executive function. The early stages, called covert or minimal hepatic encephalopathy, produce changes that are subtle enough to be missed entirely in routine conversation. Slightly slowed reaction time, mild difficulty with complex tasks, a personality that seems slightly off. These changes are detectable on neuropsychological testing but invisible on standard blood work. Studies show that up to 80% of patients with cirrhosis have some degree of covert hepatic encephalopathy that neither they nor their families have identified. As the condition progresses, confusion becomes obvious. The person becomes disoriented to time and place. Sleep is reversed, awake at night, drowsy during the day. Speech becomes slow and slurred. In severe cases, the person cannot be roused. This is overt hepatic encephalopathy, and it requires emergency hospitalization. The transition from subtle personality change to unconsciousness can happen within hours during an acute trigger, an infection, a gastrointestinal bleed, or dehydration. Sign 8. The emergency signs and what to do now. Everything before this is the liver asking for attention. What follows is the liver running out of time. The liver has a threshold. Below it, it compensates silently. Above it, multiple systems collapse simultaneously, a state called acute on chronic liver failure, where the mortality rate within 28 days exceeds 30% without intensive intervention. There are signs that indicate this threshold has been crossed, or is about to be. They do not belong in a GP appointment next week. They belong in an emergency department tonight. 1. Vomiting blood or passing black, tarry stools. This is a variceal bleed, ruptured veins in the esophagus or stomach caused by portal hypertension. Without emergency intervention, mortality from a first variceal bleed reaches 15 to 20%. 2. Sudden severe confusion or inability to wake properly in a person with known liver disease. This is overt hepatic encephalopathy, and it can progress to coma within hours. 3. Abdomen that is suddenly more distended, hard, and painful with fever. This suggests spontaneous bacterial peritonitis, infection of the acidic fluid, which has a 20% in-hospital mortality rate. 4. Jaundice that has appeared or worsened rapidly over days, combined with right upper abdominal pain. 5. Any combination of jaundice, dark urine, pale stools, and fever. This is ascending cholangitis and can become septic within 24 hours. If none of those apply but several earlier signs do, fatigue that has lasted months, an abdomen that seems larger than before, eyes that look faintly yellow, skin that itches for no visible reason, the next step is simple. A liver function blood test, an ultrasound, and an honest conversation with a doctor. The liver does not ask for much. It filters 1.4 liters of blood every minute. It works through injury without complaint. It rebuilds itself when given the chance, but it cannot tell you when it is in trouble. That is your job. Now you know the signs. Don't wait for the loud ones.